Students, this is Dr. Weaver. As promised, I informed you that I will create a voiceover on the thyroid and antithyroid drugs, something we were not able to get to while in class with so much else going on. So I'm going to try to make this as short as possible. It isn't really a whole lot of slides as we see in some of the other topics that we've covered, but so I should be able to get through it fairly quickly. One of the things I want to, a bit of advice I want to give to those who might still be struggling in this course, and more specifically with pharmacology. Well, actually, this can apply to pharmacology and your med-cert courses that you're taking. One of the things I would do, or the procedure I would take as you study this material, is so let me show you here quickly. Um, let's see. I'm going to share my desktop with you. Let's see. Actually, I wish I could have brought that over here. Actually, I think I can. I'm gonna bring this over here. Um, I'm using a dual monitor, so I'm just trying to set everything up the right way, so I can show you what it is I need you to um, take a look at. So my approach would be is when you're looking at before you actually look at the material, before you actually get into the readings, is you should first of all try to really read before you come to class. Most of you are probably hearing the information for the first time when you see me. When you come to class, and of course, by that time, when this new material is coming to you, you know, you kind of put up a little resistance, you know, and mentally that is, and it's much more difficult to comprehend the material because you haven't had at least a first look at it, if you will. Now, I have heard different ones tell me that they were told to, to read their objectives and try to answer them basically as one goes along, as they, basically, you read your objectives and then look in the book for the answers. That is an approach that I don't personally recommend. What I would do is I would certainly, so let me go ahead and share my desktop as I said. Um, so it always looks weird. Where's my share? All right. Uh, let's see. Gosh, this looks so different. This looks very different. All right. Hmm. So let me see. Well, I think that's the one I want to share. All right. So I should be sharing this now with you. So what I would do, if I were you, is I would certainly read my learning objectives, because essentially what the learning objectives are going to do is give you a layout of the material in that particular chapter. All right. You just want a general layout of what you're going to be reading about with respect to, whatever the topic is. In this case, thyroid and antithyroid drugs. Right, like it talks about identify hormones produced by the thyroid gland. So we know that in our readings we're going to come across that information. Explain the uses, general drug actions, adverse reactions, contraindications, precautions, interactions of thyroid and antithyroid drugs. we're going to come across this material. Distinguish important pre-administration and ongoing assessment activities the nurse should perform with a client taking a thyroid or antithyroid drug. Again, same thing. We're going to essentially come across this material in our readings and examine ways to promote an optimal response to therapy, how to manage adverse reactions, and important points to keep in mind when educating clients about the use of thyroid and antithyroid drugs. So this, so now we have a general idea of what we're going to come across through our readings. So what I would do is the first time I would just do a general read of the entire chapter. I wouldn't take notes. I wouldn't highlight. I wouldn't do any of those things. I would just do a straight read of the material. Right. All right. So once you do that, all right. Then what I would do if I were you is when you come to class, and of course I we'll have this discussion about that material. Let me go ahead and elucidate or make it more clear to you what you just read. Right. You'd be more familiar with the material if you read first. You would be more engaging. You'll have some questions for me at those times. But then, like I said, allow me to more or less give you the second read through my lens. All right. Um, I want you to read it first and then let me open it up. Let me make it more clear for you. All right. And then afterwards, at some point in time, when you're at home and you're studying and whatnot, go back through the chapter again. So in other words, independently, you're going through the chapters twice, but then you're depending on me between those two independent reads to allow me to open things up and make things a whole lot more clear for you. I think you will see a tremendous difference in your comprehension of the material, especially when you do it first and then I do it and then you do it by yourself again. I guarantee you things will look quite different afterwards. Another thing I want you guys to think about, let's see if I can pull this one up. Let me stop sharing and then reshare again just to make sure you see what I'm trying to show you. All right. I think I want to show you. Let's see what that one is. Learning objectives. Nope, not that one. All right. Actually, I need to change that. Give me just a moment. This just looks really weird to me. The way teams look. Um, all right, let me see if that's it. Yeah, that's it there. So let me share this one. So what I want to show you about this one is, so as we go through the different sections of your textbook regarding the different drugs, right? And as we really delve into more or less, the details of the drugs, as long as you can truly understand that material as we go through the drugs, by the time you get through these slides where it talks about the pre-admission assessment, basically your assessment information, right? I'm kind of going through each one, your ongoing assessment, right? Your nursing diagnosis information. So when the readings begin at those points, all right, as long as you have really paid attention and you really understand the drug, then the material in this particular section will become a lot easier, right? So, for example, when we're studying about, let's say, levothyroxine, some of the details of levothyroxine is where the author would tell you that this medication should be taken on an empty stomach, should be taken early in the morning for better absorption and so forth. Well, that information you're going to see again, as you go through this the last part of the chapter when you get into the nursing process. I wanted to see. Um, let's see. See right here. This is under implementation. So where it says administer or take thyroid hormones once a day early in the morning, preferably before breakfast on an empty stomach to increase absorption. See, you're basically saying again what we've already went over earlier when we were looking at the details of the information. So make sure you really pay attention as you're reading about the disease. Excuse me, about the drugs and all the different components of the drugs, the mechanism of action, the adverse effects and reactions, if you will, and all the other information, because you're going to see it again when begin to look at the nursing process. All right. It's kind of like if you're doing education for a patient. If you understand, the disease process, for example, then based on that information, you can develop a teaching plan in order to educate a patient on a particular disease process. Again, that health promotion and maintenance, which is one of the components of the NCLEX, um, you're going to be tested on that material. So if you really know the disease process itself, then you should know how to what information would be required in terms of teaching these patients. So anyway, I'm going to go ahead and begin this voiceover. So let me share again. Uh, let's see. Slide presentation. All right. I'm going to go ahead and share again. Let's see. I think that's it there. All right. All right. So we have already looked at, all right, let me back up. So today we're looking or our discussion would be about thyroid and antithyroid drugs in chapter 42, Introduction to Clinical Pharmacology. Um, we have already talked about the learning objectives, and so we already know that these objectives of the information we're going to come across in our readings will entail these learning objectives, and so that gives us an idea rather of the layout of the readings, if you will. All right. Now, here, what I want you to do is think about. So, we're going to be looking at thyroid hormones, in particular, T3, T4. We'll discuss, the thyroid stimulating hormone as it is listed here, because this is the stimulating hormone that is produced in the anterior portion of the pituitary gland that actually stimulates the thyroid to produce that T3 and T4. So essentially, here is here's your hypothalamus. The hypothalamus is a part of the brain, but then you have this master gland here where it's like attached to the hypothalamus, although it isn't the hypothalamus. And remember in class when I talked to you guys about the anterior part of the pituitary gland, and then you have just look at my cursor, you have the posterior aspect of the pituitary gland. So what happens is when our body detects that we don't have enough T3 and T4, what happens is the TSH, which is the thyroid stimulating hormone, all this hormone does is stimulate. It doesn't produce the hormone T3, T4 by itself. It is just a stimulator, right? It's like a catalyst of sorts. All right. And so the TSH is released, and then, of course, that hormone, not the hormone, but the stimulating hormone, travels from the anterior part of the pituitary gland to the thyroid gland itself, and it is this thyroid stimulating gland or rather hormone that will cause the thyroid hormone to produce the T3 and the T4 hormone that we need essentially for metabolism. All right, so that's how that works. This is all a part of uh, the um, the endocrine system. All right. Now, the thyroid gland is located in the neck, in the front of the trachea, and I think there's another picture that I can show you what that looks like. Take a look at though at Figure 42.1. This is a highly vascular gland, and of course, it manufactures or it makes or secretes two hormones, in which I've already discussed, the T3 and the T4. Now, the purpose of these hormones is to help control the body's metabolism. When the thyroid functions properly, this is known as euthyroid or normal thyroid state. So you have your hypothyroidism, which means you're not producing enough, you don't have enough T3, T4, and you have your hyperthyroidism when you have too much T3, T4 hormone. But then there's a normal state that we refer to as euthyroid, which is what we're actually trying to achieve. Now, when the thyroid functions normally and the level of circulating thyroid hormone decreases, the anterior lobe of the pituitary secretes this thyroid stimulating hormone that I just spoke about. Now, TSH it stimulates the cells that are located within the thyroid gland to release the stored thyroid hormone. All right, it's what I showed you as we look at this image rather. And of course, this process is known as a feedback mechanism. So when you don't have enough, right, of the circulating hormone, the positive feedback loop kicks in. All right, because the positive feedback loop is saying we need more thyroid hormone, and so the positive feedback loop kicks in, and then once we get to a certain healthy level of that hormone, then the negative feedback loop will kick in and say stop, stop. We don't need any more. We got enough. Stop. All right. So think about that negative and positive feedback loop. Positive mean we don't have enough, so we stimulate the thyroid to produce the thyroid hormone, and the negative feedback loop says we got enough. We don't need to produce any more. Just as simple as that. All right. Now, when the thyroid does not work correctly, one of two conditions related to the hormone producing activity of the thyroid gland will occur. And so if it's producing too much T3, T4, we're going to have hyperthyroidism. If it is not producing enough of that hormone, then we go into a hypothyroidism state. All right. Now, in Table 42.1, you will see symptoms of hypothyroidism and hyperthyroidism. So take a look at that. All right. I wanted to also mention that the thyroid also secretes what is called calcitonin. Right. This is produced by the thyroid gland, and calcitonin works in the opposite direction. It essentially lowers the blood calcium levels by inhibiting the destruction of, basically, it doesn't allow the bones, which contains calcium, to break down. See, whenever you it's called osteoclast. So whenever you break down some of the bone, it releases calcium from the bone into our bloodstream, right? And that's what gives us our calcium levels. Um, and so this particular hormone, calcitonin, also aids in it promotes rather the excretion of calcium by way of the kidneys, right? So it either stops or inhibits the bone from breaking down in order to get calcium from the bones, to give us adequate levels of calcium, but it can also stimulate the kidneys to excrete or to get rid of the calcium. So that's what that does. T3, T4, and also calcitonin. All right. Now, I really love this particular slide here because it gives you it kind of get well it more or less juxtaposes hypothyroidism against hyperthyroidism and tells you what that looks like in a patient. So when someone has hypothyroidism, essentially everything is slowing down. You see, if you think about it, all of our body parts, every organ and tissue in our body is made up of what? Cells, right? And those cells require nutrients in order to be healthy, to carry out their functions. And so, what the T3 and T4 does, as far as the thyroid hormone, is that it enables metabolism of those nutrients so that the cells, these different cells in our tissues and organs, would be able to utilize those nutrients so that, again, they might be healthy. All right. So when someone has hypothyroidism, they have very little T3, T4 circulating in their blood, and therefore everything is slowed down. Everything is slowed down, right? It's not operating at a kind of hyper um, speed, if you will, as you would see in hyperthyroidism, but everything is slowed. Right? These patients, they can have hair loss, a puffy face. This is the hypothyroidism. The heart beat slows down, or bradycardia. They gain weight because, again, their metabolism is slow, right? They also become constipated. All right. And also another important thing to know about hypothyroidism is that these patients have cold intolerance. What that means is it can be 90 degrees in a room, right? Wherever. And these patients would be cold. They would have to cover up in a blanket or something or wear layered clothing. The flip side of that is if we're talking about hyperthyroidism, these patients have bulging eyes. Both of them have goiters. Goiters is it looks like a golf ball on the side of the neck. All right, and you see these in these patients who have a hypo or hyperthyroidism. All right, they have a rapid heart rate. In other words, tachycardia. They have weight loss because the metabolism is burning significantly. Especially these hypermetabolic states where it's just burning up. You're burning up your nutrients, your macronutrients. Macronutrients being your carbohydrates and your proteins and your fats. You're just burning it up. That metabolism is just going very fast. You have a lot of circulating T3 and T4 um, circulating in your blood. All right. So these patients, it's hard for them to maintain their weight. So these are the types of patients that you have to really increase the calories and whatnot, because otherwise, they'll waste away. Instead of diarrhea, or rather constipation, they would have diarrhea. All right, because everything is just moving and burning and so forth. They both will have infertility issues, but on this side of it, as far as hyperthyroidism, they have heat intolerance. So these patients it could be 30 degrees outside, and they'll probably be outside with a tank top on. All right, they have this heat intolerance. Now, you say, well, why is all this important? Even though this is dealing with the disease process that we will study in med surge, this is important as we talk about these drugs because, for example, if someone has rather hypothyroidism, look at the heart rate. The heart rate is typically slow. They can be in bradycardia, meaning they can have a heart rate of less than 60. But if I begin to give these patients thyroid medications like levothyroxine, right? Because I'm trying to restore that reduction in their T3, T4 hormones, right? And so if I put them on that medication, then I want to see that heart rate go from a slow heart rate to a more normal heart rate. I want, for example, I want them to go from that 45 beats per minute to at least between 60 and 100 beats per minute. Um, I want them to begin to lose weight because remember, in hypothyroidism, they gain weight because everything is slowed, right? You're not really burning much of anything. And so, what I want to see, in other words, just kind of imagine this being a euthyroid. I'm trying to get them in the middle here. So I want to see some weight loss. All right, because now they're burning some calories because I have them on this supplemental, hormone medications, thyroxine, for example. I don't want them to be on the other extreme of it, or hyperthyroidism. I want them to be somewhere in the middle, that euthyroid. Now, here's something that can happen. So this patient with the hypothyroidism, they can be prescribed thyroid medication like levothyroxine, or Synthroid is another name that we call it. And so they begin to lose weight. They begin to get in a euthyroid or normal thyroid state because there's enough or adequate or normal T3, T4 circulating in this patient's blood. But then sometimes, if the patient is getting too much, it'll push them over to the other extreme. And so these patients who had a slow heart rate, now they're tachycardic, or now they are really losing a lot of weight. Now I'm sorry, yeah, usually losing rather a lot of weight, but also they're having a lot of diarrhea. All right, so you can go from one extreme to the other. All right. And so when that happens, of course, then physicians will typically titrate some of that medication downward, right? Titrated until the patient's, or titrated to the patient's response. Titrated until the patient now goes from tachycardia to more like a normal sinus rhythm or a normal heart rate between 60 and 100. All right. So that's why that's important. Or, like, for example, if they have hypothyroidism and I'm giving them the thyroid medication, now all of a sudden they have this heat intolerance. Well, we're giving them too much. And so the physicians would typically titrate the medications downward and will push them right back, hopefully in that euthyroid or that normal thyroid state. So this is why this is important for you to really study and also understand. All right. All right. So when we talk about hyperthyroidism, there's different types of hyperthyroidism as well as hypothyroidism. But let's focus on the hyperthyroidism. So if the client has a condition such as a Graves' disease, this is still a form of hyperthyroidism, but it's an autoimmune disorder. Something is attacking this patient's thyroid, right? Um, so essentially, what this means is that the thyroid gland is going to work harder, all right, to produce the T3, T4 hormone. And these patients are going to develop what we call a goiter. And it looks like, again, a golf ball on the side of the neck, but it's actually an enlarged gland, a thyroid gland, all right? Now, hyperthyroidism can also be caused by inflammation. All right. And this condition is called thyroid toxicosis. So when the thyroid glands become inflamed, everything really goes hyperactive, and I mean like really go hyperactive, right? To the extent that there's some symptoms I'm going to discuss with you that when the patients go into thyroid toxicosis, everything is working in hyper overdrive state. All right, and we'll talk about that. Now, if hypothyroidism is caused by a condition such as, let's say, someone is pregnant, and if it's correctable, it may be treated with one of the antithyroid drugs that we will be discussing. Now, if the condition is not correctable, then we give these patients a radioactive iodine, all right, to swallow. in order to destroy the thyroid so that it stops overproducing so much hormones. You see, so in some cases, the thyroid may be removed surgically, but it is a difficult procedure. To remove the entire thyroid gland, and that's why irradiation is the usual treatment. If Wish I can let me just give you this image here of what I'm trying to show you. Uh-oh. All right. So, all right. Let me go ahead and share this again. Um, oh, that's how that works. All right. So you don't really see this, but all right. So this is the thyroid gland here. It looks like a butterfly. Well, behind this thyroid gland, you have like these, looks like peas, right? And each of these wings, and that's the parathyroid gland. The problem with removing the thyroid gland is that you will inadvertently remove the parathyroid gland as well. And remember, the parathyroid gland, it regulates your phosphorus and your calcium, which has an inverse relationship. When the calcium is high, the phosphorus is low, and then vice versa. That's how that works. But when you try to surgically remove the thyroid, it is a very difficult procedure to undertake, right? Um, all right, so let me go back. Um, so what the physicians will end up doing, actually, I want to get rid of that. Yeah, let me get rid of that. What the physician will end up doing is um, physician will, all right, just want to make sure I share this again. What the physician will do is, as I mentioned, is uh, they would give the patient basically a radiation, right? A radioactive material. Uh, they put this radioactive material in this iodine because the thyroid gland loves iodine. And so if I put the radioactive material in the iodine and the thyroid takes up that iodine, it's also taking up the radioactive material. And what the radioactive material does is it destroys some of the thyroid gland. And if I can destroy much of the thyroid gland, then I then begin to produce less T3 and T4. All right. So we can do about drugs, but we can also irradiate the thyroid gland to decrease that overproduction of thyroid hormone T3 and T4, and then but we can also surgically remove it, which is a whole other problem in and of itself. It comes with its own disadvantages, if you will. All right. So that's what that looks like. Uh, All right. Now, so we talked about Graves' disease, which is still a form of a hyperthyroidism, but it's an autoimmune issue with these patients. Um, let's look at hypothyroidism. Um, all right. So there's another type of uh, hypothyroidism. We'll get into that. But what I wanted to also tell you initially about hypothyroidism is that when the thyroid is surgically or radiologically removed, when it is removed, all right, the patient is going to become hypothyroid. Why? Because we're removing a gland that produces T3 and T4. So so if you think about it, the patient that has hyperthyroidism, right? This increase, a significant increase in T3, T4. All right, and so I need to find a way to decrease the amount of that hormone, and the only option might be surgically, right? And so then you remove the thyroid, and of course now they go to the other extreme of hypothyroidism, right? Now Without a functioning thyroid gland, because it is removed, this patient is going to have to take a thyroid supplement for the remainder of their lives. Because if their thyroid gland is not producing it, then we have to give them a synthetic form of the thyroid or hormone, so that their metabolism system or the metabolic system will work. All right. Now, hyperthyroidism also can be caused by disease such as this one that you see, Hashimoto's thyroiditis. All right. This is actually also an autoimmune disease. Now, Hashimoto thyroiditis causes the thyroid to become inflamed. So we're talking about this inflammation. So rather than increasing hormone production, as you would see in Graves' disease, an autoimmune disorder as well, in this situation, the inflammation is going to stop this gland or prevent this gland from producing more hormones. All right. So with the Graves' disease, it causes the thyroid hormone to produce more thyroid hormones, T3, T4. But with Hashimoto's thyroiditis, it is going to cause inflammation of the thyroid gland and causes a reduction in the production of T3 and T4. So again, you have this hypothyroidism state. Again, thyroid hormones are taken for supplement until the condition is corrected, if it is correctable. If it's not correctable, then these patients will be on it for the rest of their lives. All right. And it can be corrected. So, all right. Let's see. I want to see something. I don't know if that'll help. Yeah, I guess that'll help. All right. Now, so thyroid hormones, let's get into that. So thyroid hormones used as a supplement, it includes both the natural and the synthetic hormones. The synthetic hormones are generally preferred because they are more uniform in their potency, right? They're more potent than the natural hormones that we get from animals. All right, so the animals would be your natural ones, and your synthetic, the synthetic form, of course, is the non-natural, if you will. Right now, thyroid hormones are listed in the summary drug table, thyroid and antithyroid drugs. So take a look at that. Now, thyroid hormones influence every organ and tissue of the body. I said that because those organs and tissues are cells, and those cells require nutrients. And the metabolic system actually helps our cells. It turns our nutrients into glucose so that our cells can use them. Right. So these hormones increase the metabolic rate of tissues and result, it causes our heart rate to increase. It causes our respiratory rate to increase as well. It raises body temperature. If the heart rate, of course, is increased, as in, let's say, tachycardia, then we get an increase in cardiac output. In other words, the amount of blood leaving the heart. And since the body is working, it is going to consume oxygen. All right. So there's oxygen consumption. The body just requires more oxygen. And of course, this metabolism, it also burns or metabolizes fats, proteins, and carbohydrates to be used by the body. Now, the exact mechanism by which thyroid hormones exert their influence on our organs and tissues are not really understood. I mean, we just don't understand everything in science, of course. Right. Now, when you think about the thyroid hormones increase the rate at which our cells burn energy, meaning they help our bodies produce energy from the food more efficiently. All right. So this affects nearly, again, every tissue, but especially the heart, the muscles, and also the digestive system. So it's important you understand what is actually taking place um, with our thyroid system. All right. Um, Levothyroxine is one of the thyroid hormones that we give to our patients. All right. Um, the uses. So thyroid hormones are used in the treatment or prevention of hypothyroidism caused by subacute or chronic thyroiditis or the Hashimoto disease or viral thyroiditis. So we give it for that. We also give it for as a hormone replacement after hyperthyroid treatment. So when somebody has hyperthyroidism and we destroy the thyroid gland, we have to place them on a hormone supplement. All right, such as the levothyroxine or Synthroid. Um, if someone has a goiter or enlargement of the thyroid gland, we place them on these supplements. If they have a thyroid nodule or multinodular goiter, meaning the goiter is just has these nodules on them, they'll give it for that. And sometimes also in some types of depression, because if someone has hypothyroidism, one of the issues they deal with is a kind of depression, and so you give these patients thyroid medications, and hopefully you can more or less regulate their mood a little better. All right, let's take a look at the adverse reactions for thyroid hormones. All right, so uh, these are also signs of overdose. So remember, this patient is in a hypo, all right, in a low thyroid or hypothyroid state. So I give this patient the Synthroid or the levothyroxine supplement, right? And then what happens is, so basically you're actually educating your patient. You're letting your patient know this is what the signs and symptoms of hypothyroidism. Remember, things are really slowed down, right? But you also teach them about signs and symptoms of hyperthyroidism. You teach them about those signs and symptoms, so that when I place you on these medications, this hypothyroid patient, I want to make sure they understand that, all right, so I'm coming out of the hypothyroid state, right? But I'm not moving into the hyperthyroid state. So I'm kind of in the middle, that euthyroid, meaning everything is working normally, got normal heart rate, I have normal bowels, I don't have either cold or heat intolerance, all right? Everything is pretty much normal. Right. And so, say if I give someone, I'm prescribing someone with the levothyroxine, which is the thyroid supplement, right? And they begin to experience hyperthyroidism symptoms. They have the weight loss, as you can see here on this slide. Let me actually open that up. Uh, I guess that is open up. Huh. All right. Anyway, so yeah, so they have weight loss, they have tachycardia, they have insomnia, tremors, flushed skin, thinning hair. These are the symptoms you're going to see in a patient who has hyperthyroidism, because maybe they're getting too much of the drug. And so then this is why I was telling you the physician would have to titrate the drugs downward, right, to get them again back into that euthyroid or that normal thyroid state, right? Once when I was at the gym, I was talking to a young lady who she had, I believe, hypothyroidism, and someone who was well-to-do, right? And one thing I was really surprised about was that she said that her physicians didn't necessarily teach her about signs and symptoms of both hypo and hyper. But we allow our patients, or part of the treatment, if you will, is to teach them about the disease process so that they know when to report things that are amiss, or that things that are not so normal, if you will, when things become problematic. So it's like you have this woman on Synthroid, for example. Well, if you don't tell her about the signs and symptoms of hyperthyroidism, and then she begins to experience these symptoms, then she probably won't know what's going on with her. So we have to teach these patients about both hypo and hyperthyroidism, because we don't want them to be one extreme to the other, or the other. All right. I hope that makes sense to you. Let's see. All right, take a look at the contraindications. Uh, Always the hypersensitivity to the drugs. If a patient has a hypersensitivity, then we know we don't give it to those patients. Uncorrected adrenal cortical insufficiency, thyroid toxicosis. Remember, thyroid toxicosis, that's when you have too much thyroid medication in your system. And so heart rate is up, respiration is up, everything is up, 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 right? And so you don't want to give it to that patient, because then you'll send them into even greater severe symptoms. Recent myocardial infarction. If the heart is working too hard, if somebody's in tachycardia, this will cause the heart muscle to require more oxygen. So it's overworking, and the heart is not in any condition, especially after it has been damaged from a heart attack. It's not in any condition to be working that hard. All right. So we don't want to give this medication to those patients. Right. Now, remember what I told you guys. You have to, as we go through this material, right? As we go through this material, we're going to see it again when we begin to look at the nursing process. So really learn it now. So when we get to that piece, then it's like you're rehashing again what you've already read. I want you to use consciously in people with cardiac disease, and of course, women who are lactating or pregnant. Right. Now, these drugs are contraindicated. Also, well, you don't want to give it. You don't want to give this medication to patients who are obese. You don't want to use it as a diet drug, right? And also, if a person is showing or has infertility, you don't want to give thyroid medications for that either. All right, it's not a weight loss medication. Right. Now, someone who has a myocardial infarction, they may still prescribe the drug to them, but perhaps in smaller doses, because they might really need it. Right. Now, take a look at the table. As you know, we always kind of look at some of these when we're in class, but basically, let's just look at a few of them. So, the digoxin and beta blockers. These are medications for cardiac management. People who have cardiac problems, right? For example, digoxin, it causes the heart to muscle to contract stronger, right? So the patient can have a better cardiac output. And your beta blockers, it can prevent your heart rate from going up, and also it can prevent your blood pressure from going up as well. And so, meaning it makes your heart work with less stress, if you will. So, what does it do? What is the effect or interaction when you give these drugs with Synthroid, for example? The thyroid hormone. It says it decreases the effectiveness of the cardiac drug. So these patients, you're not going to see, for example, digoxin is supposed to give you better contractions of the heart. So you'll see weaker contractions. As far as beta blockers, you want to see a lower heart rate, lower blood pressure, but when you give these drugs together, there'll be an increase in heart rate and increase in blood pressure. So the heart is going to be working harder. Look at the second one. It says oral anti-diabetic and insulin. And of course, as we know, these drugs are used to treat diabetes. But given these drugs together, it will cause an increase in an increased risk of hyperglycemia. All right. So essentially, the diabetic medication is not really working all that well once you combine these drugs. And of course, the third one, we just do that one, oral anticoagulants. It prevents blood clots. And giving these drugs together, you have prolonged bleeding. All right, and Coumadin is given, although we, in layman's terms, we say keep the blood on the thinner side, but essentially we don't want blood clots to develop, but we also don't want to, bleed to death, if you will, bleed a lot. So that's the interaction table. So just take a look at the rest of that when you get a chance. All right. Now, these are the anti-thyroid drugs, and let's look at their action. All right. Now, anti-thyroid drugs, or also what we call thyroid antagonists. So when you think about the word antagonist, it means against. Agonist would mean for, but antagonistic. Well, just think about antagonistic. It means to go against, right? So we use these anti-thyroid or thyroid antagonists, right? Medications that work against the thyroid in order to treat hyperthyroidism. Got to keep that in mind. It treats hyperthyroidism. Now, in addition to anti-thyroid drugs, hyperthyroidism may be treated by the use of radioactive iodine. Remember, I told you that the thyroid gland has an affinity for iodine, and so therefore they'll put radioactive material in the iodine, and the thyroid gland has a tendency of taking that up. And of course, it is that radioactive um, properties of this medication that would destroy some of the cells of the thyroid, so you produce less T3 and T4. All right. They also treat hyperthyroidism again by surgery. They may do what we call either a subtotal or total thyroidectomy. In other words, they remove the thyroid gland, which again, as I mentioned to you, is very difficult to do. So actually treating it with this radiation is a bit more safer. Because again, you take out the thyroid, you inadvertently remove the parathyroid gland as well. All right. And remember, the parathyroid gland is sitting in the back of the thyroid gland. You can't really see it with an anterior view, but you remove that. So now you have to take supplements for your T3, T4, but you also have to take a supplement for the parathyroid gland because it's been removed. And so you need to be able to regulate your calcium and phosphorus as well. All right. Now, anti-thyroid drugs inhibits or prevents the manufacture of the thyroid hormone. So it stops the thyroid from producing T3, T4, right? Because remember, when you're in a hyperthyroid state, you're producing too much T3 and T4. So this drug inhibits that. So you get less T3, T4, right? Now, they do not affect existing thyroid hormones that are already circulating in the blood or that is stored in the thyroid gland, right? And so for this reason, therapeutic effects of the antithyroid drugs may not be observed for about 3 to 4 weeks. So it does take a little time. And this is important because, especially when we get into the nursing process, that educational piece, we have to let patients know that you're not going to receive immediate results, not with antithyroid drugs. You see a little faster results with the radioactive iodine, that one I-131. You see it faster with it than you do with the drugs that you give these patients. All right. So again, if a patient has let's say hyperthyroidism and all those hyperactive symptoms that you see, for example, tachycardia. Well, you may not see a normal heart rate for another 3 to 4 weeks because it is going to take a little time for the drug to take effect. So that's very important education to give to your patients. Now, the radioactive iodine, or I-131, is used because the thyroid, again, it has this affinity for the iodine. Now, what happens is the radioactive isotope accumulates in the cells of the thyroid gland, and this radiation it destroys the thyroid cells. Remember, the thyroid cells is what actually makes the T3 and T4. It's what the thyroid stimulating hormone stimulates in order to produce the T3 and T4. But when you give these patients this radioactive iodine, it actually destroys those cells. All right. Without damaging the other cells throughout the body. So it's a little more focused on the thyroid gland itself. Now, because the radioactive material is carried in iodine, it is important to assess the client's response to what? Iodine allergy. You have to ask the patient, are you allergic to iodine? Because you may not be able to give the I-131 if they are. All right. Now, although using isotopes is this radioactive isotopes is preferable, it may not be recommended for every patient. Therefore, the patient might have to have a thyroidectomy instead, right? Now, antithyroid drugs might still be a given before a patient goes to surgery because what you're trying to do, or you're trying to temporarily, before you do the surgery, get the patient in a normal or a euthyroid state before doing the surgery. You don't want to take a patient to surgery and they are in a significant either hypo or hyperthyroid state. You want them to be in a more normal state, right? Because it's safer for their surgery. So I want you to keep that in mind. Um, when used for this particular reason, the vascularity, all these blood vessels are in the thyroid because the thyroid gland is very vascular, has a lot of blood vessels. When you give these drugs, it reduces the vasculature in the thyroid gland. And they do this by giving these patients what is called a potassium iodide, or something like that. And once you reduce the vascularity, all the vasculature in the thyroid gland, when you go in and do surgery, they'll bleed less. They're bleeding less because they have less blood vessels in the thyroid gland. And um, so they don't bleed as much. And well, during surgery, but they also don't bleed after a lot after surgery as well. Again, because with that potassium iodide, we're reducing the vasculature in the thyroid gland. So it just makes the surgery more safer. And again, we don't want to send patients to surgery when they're either hypo or hyper. All right, we want to get them in the normal thyroid state or euthyroid. All right. Hopefully that make sense to you. And also keep in mind about the thyroid gland. Thyroid gland is located in the neck region, as you can see here. And if you do surgery on that part of the neck, remember when you cut into all that tissue, it's going to cause inflammation. And so these patients are at risk of having their respiratory, their trachea closed off because of the inflammation, the swelling. All right. Also keep in mind that you're removing the thyroid gland, but you also are inadvertently removing the parathyroid gland. So you have to check these patients' calcium levels, right? Calcium and phosphorus levels. Another thing is With these patients, you're actually watching for respiratory distress. Keep that in mind. But also, you want to take your hand and you want to place it behind the neck and feel for wetness because when these patients are lying supine, blood tends to pool in the back of the neck, and so you want to put your hands back there just to make sure they are not bleeding. All right. Let's see. Let's see. All right. So the antithyroid drugs are used. So before thyroid surgery, so we talked about this already. Actually, I don't know why this is coming up again. So anyway, so before the surgery, we want to go back to euthyroid state, or at least get the patient there. Potassium iodide may be given orally with methimazole and propylthiouracil to prepare for this thyroid surgery. Now it says in the medical management of hypothyroidism, but I think they meant to say hyperthyroidism, right? This is why you're giving it. So I think this is another error that we have caught. You know how we do in class, we tend to catch these things. And again, it's used to treat hyperthyroidism and select cases of cancer of the thyroid with radioactive iodine. Iodine is I-130, 131I. All right. So that's why I think this is supposed to be a hyperthyroidism. Lots of mistakes in this book I noticed. All right, take a look at the general system reactions. You have hay fever, sore throat, skin rash, fever, headache, nausea, vomiting, and also paresthesia. It looks like sore throat is probably one of the greater reactions that we are concerned about that we certainly want to report. Now, some of the severe reactions when taking these antithyroid drugs is agranulocytosis. And basically, that's when you have a reduction in your white blood cells. Anytime you have a reduction in your white blood cells, these patients are prone to infection, and so we have to teach them about washing their hands and staying away from crowds and staying also away from sick people. Right. You also have the exfoliative dermatitis, so it affects the skin. Granulocytopenia, so the granules of the white blood cells, essentially, they're low as well. These are certain white blood cells. There's also hypo or prothrombonemia. And this is actually prothrombin is created or produced by the liver, and this causes patients to clot ultimately if, let's say, you have a cut. Then prothrombin is a part of that coagulation cascade or process that leads to a clotting of that area so you don't bleed to death. And so you have less of it in your system when taken with this drug. There's also drug-induced hepatitis. That's probably where the hypoprothrombinemia comes into play because the liver actually produces, this product. And also acute pancreatitis is another one, another severe adverse reaction. All right. Let's see. As far as contraindications, if there's hypersensitivity, obviously, pregnant and lactating women, and this is a category X, so that's pretty severe. They can have a pretty severe response. And precautions, they will still give this medication to these patients. It is considered a category D. And the reason so is because these medications, which are for hyperthyroidism, it can cross the placenta and cause the baby to become hypothyroid or develop hypothyroidism. So it can affect the fetus. So we have to be careful. All right. They actually give these patients what they call PTU. Um, is one of the preferred drugs to use in hyperthyroidism because it does not cross the placenta. I think the PTU is this propylthiouracil. I think that is that one. So, yeah. Let's see. Take a look at the interactions. Of course, given with an anticoagulant, it can cause increased bleeding, so we have to really watch that. All right, so now we're in the nursing process. This is really important now. So all that we have learned about this drug, we're going to see it again. But how do we reply, not reply, how do we apply this knowledge in the nursing process? And that is going to be the key. All right. Now, often a patient is diagnosed with hyperthyroidism, is treated, and then, of course, they become hypothyroid. So they go from one end of the spectrum to the other. And of course, they're going to require thyroid medications in the way of, Synthroid, levothyroxine, and so forth, in order to, stimulate their um, or rather to give them that the thyroid hormone that they need, that their cells, organs and tissues need, rather, is what I'm saying. Let's see. All right. So as far as pre-admission assessment, objective data, we always want to do a general appearance assessment of the patient, know what they are at the baseline. We want to know what the vital signs are because remember, when they have a hyperthyroidism, they are going to they look a certain way. I mean, the hair is thin, they're sweating, and they're losing weight, and all these things. Their heart rate is up, right? The blood pressure may even be up. Respirations are up, and so you want to get a baseline. This is all about getting a baseline. You're looking at their weight. If they have hyperthyroidism, they have a decrease in weight. If they have hypothyroidism, they have a decrease in weight. You also want to look at their TSH levels, T3 and T4, and whether or not they have serum thyroid antibodies. Remember, the autoimmune disorders, when antibodies, if a patient is infected by a virus, for example, the body is going to produce antibodies against that virus. Remember, that virus is the enemy, is an antigen, and the body of the immune system produces antibodies. And so, if you detect antibodies in this patient, it's probably because they had a viral infection, right? They can't determine if there was a virus, but they can determine that a virus was present because why would antibodies be present in our system unless a virus was present? Anyway, so all of this is to for a baseline, so that when we begin this therapy, we want to see things improve. Because if they don't improve, maybe it gets worse. Then we need to make some adjustments or in the patient's treatment regimen. So that's what that is all about, that baseline. All right. Subjective current symptoms experienced by the client through their own lens. And of course, we want to know about an allergy history because iodine and contrast dyes, these patients, if they're allergic to these things, then we need to know. We may not be able to give this patient this 131 I or the radioactive material because remember, the radioactive material is placed in the iodine, right? And the patient may not tolerate that well. History of symptoms or other chronic health conditions, we need to know about that. I skipped the question here. The assessment is continues to be ongoing. So we want to observe the client for adverse effects when they're receiving the antithyroid treatment. We want to ask the client about relief of symptoms, right? If this patient is feeling very tired and fatigued, and they're gaining weight and all these things, that the heart rate is really low, all right? And then once I start them on this treatment, are they getting any relief? Are they feeling more energetic? Is their heart rate becoming more normalized? How do they feel overall? Again, we want to know if things are improving. We want to ask about the presence of side effects. So, if the patient has agranulocytosis, meaning low white blood cells, we want to know: are they fatigued? Do they have a fever, sore throat, easy bruising, bleeding, coughing, or any signs of infection? Because remember, this is what these drugs do, the side effects, and so we want to know if they are experiencing these side effects. Thyroid toxicosis. Remember, that's when you have an increased amount of T3, T4 in your system. These hyperthyroid patients, and so we want to know if these patients experiencing thyroid toxicosis, they will have high fevers. These are the symptoms I was telling you about. They have high fevers, extreme tachycardia, 150 beats a minute, maybe or higher. They have diarrhea and vomiting and change in mental status. So, in other words, thyrotoxicosis is an even more exaggerated response to a lot of or a significant amount of T3, T4 in the system. Um, so rapid development of these side effects is again called thyroid toxic crisis, or it's also called thyroid storm. It's called thyroid storm because it just happens so quickly, and it's actually a medical emergency. These people they can die, so it needs to be addressed almost immediately. All right. Look up the ongoing assessment. So that as far as the thyroid supplements, such as a Synthroid or levothyroxine, so the full effect of the therapy may not take effect for several weeks. Remember, I told you that. Because remember, when these patients are given, well, this is for hyperthyroidism, and so we're trying to um, decrease those symptoms. And so you still have the circulating T3, T4 in the bloodstream, and also you have some of it in the cells, right, of the thyroid gland. And so it's going to take some time for that to be used up, if you will, and so that they can turn to a more normal T3, T4 levels. Right. So, but we are looking for therapeutic responses, signs and symptoms. We're looking for it to subside, if you will. So, if someone, of course, we're looking for weight loss, of course, in someone who has hypothyroidism, mild diuresis because we have better perfusion to our kidneys. We want to see an increased appetite because when you're in hypothyroid state, you don't want to eat. These patients experience a lack of desire to eat, and so we want to see an improvement in their appetite. If they're in a hypothyroid state, we want to see a better heart rate. We want to go from bradycardia to a more a normal sinus rhythm, right? We want to see decreased puffiness of the face, hands, and feet. This all again shows improvement. Um, we also assess the patient for feelings of well-being and increased mental activity because again they're more fatigued and they don't want to do much and so forth. Now, so thyroid hormone replacement drugs are not equivalent to each other. So the patient should not be changing brands or types of thyroid hormone drugs without first checking with the primary care provider. All right. So the primary care doctor needs to determine the equivalent dosages when changing medications. So that's something we have to educate these patients on. Take a look at the nursing diagnosis, ineffective protection related to urinary elimination of radioactive isotopes. This is important because if these patients go home on these where they have a prescription of these radioactive isotopes, we have to protect other family members from that patient because they're going to have this radioactive material in their bodies, right? And we'll talk about that. Altered health maintenance related to consistent dosing or titrating of dose. And this is what is going on throughout this therapy. We're constantly monitoring this patient to see if the symptoms are getting worse, if they're getting, or better. If they're getting worse, then titration is going to be very important. We have to adjust these dosages based on the patient's response to therapy. Infection risk related to adverse reactions. Remember, agranulocytosis occurs with these patients. And so we want to make sure that we are teaching these patients to, again, avoid the crowds, washing their hands, and so forth. Alter skin integrity related to adverse reactions. I believe this particular drug can cause skin rashes and I think it's the dermatitis and what have you. So we have to again look out for these different signs and symptoms. All right. Let's see. Expected client outcomes depend on the reason for administration of the drug, but include. So we want optimal response to the therapy, management of adverse drug reactions, we want to manage the drug reactions. We don't just want to ignore them, right? Because if we can support the patient through these adverse reactions, then they may be more adherent to the medication, um, right? All right. So promoting optimal response to therapy. So again, we're still talking about the antithyroid treatment. So if a client is with a hyperthyroidism, has tachycardia, that's a normal symptom for these patients, or they also have palpitations. It feels like their heart is jumping a beat or like it's racing. Right. The doctor may prescribe propranolol, which is a beta blocker, until the therapeutic effects of the antithyroid drug takes effect. So, what does that mean? So, these patients, when they're in a hyperthyroid state and they're taking medications to try to correct that, they're still going to have this tachycardia. Until the antithyroid drug takes effect. So what they will do is put these patients on a beta blocker to try to calm down that heart rate, make the heart rate lower so that the patient can tolerate it or the symptoms will be more tolerable. And that's what propranolol does. It blocks those receptors on the heart in order to decrease the heart rate. Right. And again, we just do that until the therapeutic effect of the antithyroid drugs takes effect. All right. Now, before home arrangements are made for or prior home arrangements are made for isolated activities when the patient with an enlarged thyroid gland is given radioactive iodine. In other words, we have to make some preparations before they go home. Right, we have to make sure everyone is safe, especially other family members, especially if a woman is pregnant or there's a baby or child and whatnot. We have to be careful. Right. So the patient stops taking anti-thyroid drugs about 3 days before the procedure. All right, before this radioactive iodine, they would stop taking the anti-thyroid drugs. This is information you can be tested on, right? So after midnight, the patient will not have any food or drink. The patient will come to the nuclear medicine department of the hospital, and they will swallow the iodine, the radioactive iodine preparation, and then of course they will return home. All right. Now, the effects of this radioactive iodine are evident in roughly about 24 hours. You see some effects in about 24 hours. But the maximum effect of these drugs will take place in about 10 to 15 days. So the patient is hospitalized, or if the patient is hospitalized, then the staff have to carry out safety precautions to make sure hospital staff is safe as well. All right. So we're preparing you either for home or we have to also be prepared if you're in the hospital. You see these signs on the doors, with like it's showing radioactivity and all that stuff. You'll see that in the hospital. All right. Let's see if I miss anything. Nope. All right. So as far as the thyroid supplement, once a euthyroid or normal thyroid state is achieved, the doctor may begin hormone replacement supplement to prevent or treat hypothyroidism. Remember, these patients, as you're treating the hyperthyroidism with the radiation, they can now become hypothyroid, and so at some point they will begin to treat the hypothyroid condition. Um, and this may develop slowly during long-term antithyroid drug therapy or after administration of the I-131. So um, again, when these patients are given the antithyroid drug, if they're given the radiation, they can become hypothyroid or develop hypothyroidism. The thyroid hormones are administered once a day, and is given early in the morning, um, and preferably before breakfast. When a patient's stomach is empty, of course, there's better absorption of the drug. Now, the thyroid hormone replacement therapy in patients with diabetes may increase the intensity of the symptoms of diabetes as well. So we have to really watch these diabetic patients because it can cause the blood glucose levels to be increased. So we have to look out for signs of hyperglycemia, possibly even DKA, depending on if you have type 1 or type 2. So make sure you watch those diabetic patients. Um, Also, with our older clients, patients, we have to watch those with cardiovascular disease. So if they develop chest pain or worsening cardiovascular symptoms, we want to make sure we notify the physician because these drugs can have a adverse effect on the cardiovascular system. Now, when the client, so for 2 to 4 days, where we talk about ineffective protection, for 2 to 4 days after the radioactive therapy client, they should be in an isolated place in the home, away from others, especially children and pregnant women, to protect them from the radiation. They should also have a private toilet facilities and flush twice after use. Now, we know that's really difficult sometimes because there may be only one bathroom in someone's house. So then what do you do with that, right? Well, you'll probably put the patient in a room by themselves with maybe a bedside commode or even a urinal and whatnot. Is how I would probably do it in a situation like that. But each situation would have to be evaluated. Now, not only should they have their own bathroom, right, but they should flush twice. You don't flush once, you flush twice. And one thing I would tell you, men should sit down to urinate because if they're standing up peeing, and remember their secretions, body secretions, is also radioactive, right? And so if they're peeing standing up, this pee is actually splashing out of the commode, and so it contaminates the area. So should be sitting down. Normally women sit down, right? Or a man would sit down if he's having a bowel movement. But in this case, if he's just urinating, he should be sitting down also. All right, so you don't have all that splashing. Um, Also, eating utensils and laundry should be cleaned separately and should not. And the client should also sleep by themselves. You don't want to again affect someone else. Um, and what else? And so instructions will be given as to how long the patient should do activities by themselves and away from others. And this typically lasts for about 2 to 4 days, so it's not really a long time. All right. As far as altered health maintenance in those patients with hyperthyroidism, clients with hyperthyroidism may experience difficulty taking drugs every 8 hours, and they may miss a dose because that means that you have to take it, let's say, um, around 7 in the morning, 3 and 11, and some people go to sleep at 7 o'clock. So it may be, or they may not get up early enough, so they may miss a dose. So that can be problematic. So what they suggest is to alternate 8-hour dosing schedules that fit the client's natural wake sleep cycle. So, for example, they may tell the patient to get up at 6 o'clock in the morning, to take the medication, and then they can go back to bed. All right. Um, and then, of course, shouldn't have did that. And then we use different tools to help remind. A patient should use different tools to help remind them or alert them when the medications are due. All right, and they got all kinds of technology out there to help patients remember. And remember, these drugs have to be given on an empty stomach, and ideally, in the well, these drugs have to be given on an empty stomach, and so just make sure this the administration coincides with the patient's meals. Uh, All right. So thyroid supplements are adjusted based on the response of client to the drug therapy. So this is individualized. And so essentially what we're saying is we're looking at this particular patient and how they are responding to the therapy. If they're responding favorably, then, we can pretty much possibly leave the dosage where it is. But let's say if the patient is now developing, when they've gone from hypo to hyper, and we're titrating downward. If they go from hyper to hypo, and we have to treat them with one of these supplements, then we want to see them again moving towards that euthyroid state. So we're just basically looking at their response to treatment, and we're adjusting the dosage accordingly. Now, we teach the client how to monitor for reactions to therapy and to document them. So, this is what I was talking about. These patients really need to know the signs and symptoms of hypo and hyper. All right, hypo and hyper, so that they can report this information and the changes can be made accordingly. Right. Now, be understanding that this may be be a frustrating process for the patient, as the primary care team makes dose adjustments based on the patient's hormone responses. And so just exercise a little patience. I'm sure it's a lot for these patients, especially if it interrupts, what their lives were like before. Right. Monitor the client throughout the therapy for adverse reactions. Again, we teach them about signs of agranular cytosis, in other words, low white blood cells. So we're looking at signs of infection. Um, and they're at greatest risk, of course, of upper respiratory infections. And so this is something they need to know and that we need to watch for. There's also altered skin integrity risk. So clients who are taking methimazole, propylglycol, can develop a rash, and so we need to, make sure we instruct them to use soothing creams or lubricants that can be applied to the rash. And soap should be used sparingly until the rash subsides. And so maybe a very mild soap should be used sparingly. All right. And the patient should also report rashes immediately to the healthcare provider so that the dosing changes can be made. All right. As far as educating the client and the family, explain the importance of taking the drug as directed and taking the drug on an empty stomach. Very important patient education information. Instruct the client to continue taking the drug even if they feel better. Because at some point they may feel better, and then kind of like what we do with antibiotics, once we start feeling better, then we don't want to take it anymore. And so we know what that does with antibiotics. So same thing with this drug. You want them to take it, even if they begin to feel better. All right. Let's see. Right. So these two medications, we want to instruct the client to take the drug every 8 hours because that helps to maintain a therapeutic level. We also want to notify the provider for signs of infection, sore throat, fever, so forth, cough. We also want the patient to weigh themselves twice a week and report weight gain or loss because, again, this will tell us if the drug is either working or not. All right. Right. Now, if the provider asks the client to monitor their pulse rate, we want to instruct them on how to do that. So we have to teach them how, just like we teach nursing students, we have to teach our patients how to properly check their heart rate. Because remember, let's say, for example, if you're hypothyroid, if you're in a hypothyroid state and you're on these supplements, we want to see a more normal heart rate, right? Or if you're in a hyperthyroid state, then we want to see we want the patient to go from tachycardia to more of a normal heart rate of between 60 and 100 beats per minute. Um, so we have to really teach them how to do this, and also avoid the use of non-prescription drugs unless the primary care provider has approved the use of a specific drug, because we know about these interactions that take place. All right. Now, as far as those who are on the radioactive iodine, we instruct the patient to follow the directions of the Department of Nuclear Medicine regarding precautions. And so they'll give you specific directions. Also, keep in mind that tenderness, swelling of the neck, a sore throat, and cough may occur 2 to 3 days after this procedure. And so this is when they may be susceptible to developing an infection. All right. As far as the thyroid hormone, we want to explain to the client that thyroid hormone replacement therapy is for life in most cases. Um, unless it is being used for transient hypothyroidism associated with thyroiditis. So in other words, the thyroiditis will likely be it's a condition that will get better, and of course they can stop taking it then. But if you have a condition where, say, if they either remove it or if they destroy it with the iodine 131, something like that, then of course it is for life, and they need to know that. Instruct the patient to take the dose prescribed and not to adjust the dose or change from one brand to another without directions from the provider, because the brands they don't have the same potency. So the healthcare provider should be contacted before you make that change. Now, again, so as far as this drug is concerned, we always take it in the morning on an empty stomach because it's better, absorbed. Instruct the client to call the primary care provider if the following symptoms occur: headache, nervousness, palpitations, diarrhea, excessive sweating, and just read the rest of that. Basically, this patient might be going into thyroid toxicosis. It's when you have too much T3, T4 circulating in the blood. And so, again, adjustments will likely have to be made. As far as evaluation, I'll go ahead and let you guys read that. I think that's a pretty easy read. That might be it, folks. Yes, that is it. All right. So, all right. So I've talked for about an hour and 30 minutes. And so I suppose that's not too bad. I kind of added, I think that first 13 minutes, just talk to you guys about, you know, how to approach this material. And so hopefully that will be helpful to you. Let's see. Is there anything else? I think that's about it. So let me know what you guys think. Maybe try an experiment. Do some reading. Do your readings on this the thyroid antithyroid medications first. Do your readings and then listen to the voiceover, and then go back and read, and then see how you do. All right, and I'll send this in an email as well, just to give you some direction again surrounding that. Anyway, I appreciate you guys for for your patience, and hopefully you will find this to be very helpful. Thank you.